This lecture is on acute complications related to hyperglycemia. These are diabetic ketoacidosis or DKA and hyperosmolar hyperglycemic state or HHS. This lecture is number 8 and the last lecture of the diabetes series lectures. By the end of this lecture, you should be able to synthesize the clinical manifestations of DKA and HHS, differentiate DKA and HHS, and discuss the nursing considerations and rationales for the management of DKA and HHS. First, let's discuss the pathogenesis of diabetic ketoacidosis or DKA. Let's break down the terms diabetic ketoacidosis. The first word, diabetic in diabetic ketoacidosis, simply means that DKA happens in a person with diabetes, almost exclusively in people with type 1 diabetes. People with type 2 diabetes can also develop DKA, but it is less common. What does ketoacidosis in DKA imply? Please direct your attention to numbers 1 to 3 on the figure to your right here. Okay? In diabetic ketoacidosis, here in number 1, there is an adequate insulin for cells to obtain glucose. There is inadequate insulin for cells to obtain adequate glucose. So the body then attempts to obtain energy by the rapid breakdown of fat stores. Here in number 2, the liver converts the fatty acids into ketone bodies, which can serve as an energy source in the absence of glucose. The ketones, however, have a low pH, resulting in acidosis, in particular metabolic acidosis. So, what precipitates diabetic ketoacidosis? Number 1 is the omission of or missed doses of insulin. This article says that 44% of DKA presenting in the hospital or emergency room is due to the omission or missed doses of insulin. Another precipitating factor for the onset of DKA would be a new diagnosis of type 1 diabetes. DKA or diabetic ketoacidosis is sometimes the first sign of type 1 diabetes in people who have not yet been diagnosed. Another precipitating factor is an infection. So, what is the clinical presentation of diabetic ketoacidosis? In the previous slide, you see here that DKA is characterized by ketoacidosis, and in terms of the labs, the pH would be below 7.3 and the serum bicarb would be below 18. So in other words, the person with a DKA is in a state of metabolic acidosis. So, because the person is in a state of metabolic acidosis, there will be a compensatory mechanism of Kussmaul breathing or Kussmaul respirations. If you click on this hyperlink, this will bring you to a YouTube video um, depicting a boy who is in Kussmaul breathing. Kussmaul breathing is a type of hyperventilation. In other words, the person has you could say deep breathing. So why is that person doing that? Uh, if you look at this equation, it's carbon dioxide plus water producing carbonic acid. So, and then carbonic acid dissociates into uh, bicarbonate and hydrogen ions. So, if you remove the carbon dioxide as an ingredient to carbonic acid, you will have less hydrogens. Okay, in other words, this ingredient removing this ingredient will produce uh, less acid or less hydrogen, because pH is really just a measure of the number of hydrogen ions or hydrogen concentration. The lower the pH, the more concentrated is the hydrogen ion. So by hyperventilating, that person is trying to get rid of the carbon dioxide. So in a person with DKA, other symptoms will be, you can see in the urine. What will you see in the urine? Glucose and ketones. Glucose in the urine is called glycosuria, and ketones in the urine is called ketonuria. You will also see a fruity acetone smell to the breath because of the ketone bodies. And then polyuria and polydipsia will manifest. One might see polyphagia, but polyphagia is not a prominent feature of DKA. More likely than not, a patient with DKA will have nausea, vomiting, and abdominal pain. And then the patient will also have lethargy or stupor. And if DKA is not treated or managed soon, the person will will excuse might go into coma and possibly even death. So again, you will have metabolic acidosis. Because of the metabolic acidosis, you will have Kussmaul breathing as a compensatory mechanism trying to get rid of the carbon dioxide. There being missed insulin, right? You will have glucose in the urine and ketones in the urine. So let's try to compare these two acute complications of diabetes. Okay. Uh, Diagnosis of diabetic ketoacidosis is based on several factors as outlined here. Blood glucose level would be greater than 250. pH would be less than or equal to 7.3. Serum bicarb would be less than 18. And serum osmolality would be greater than 300. The normal osmolarity is between 275 to 295. So these would be the criteria for diagnosing DKA. With HHS, which would be hyperosmolar hyperglycemic state. Okay. Sometimes you can see in the literature that these words are interchanged. Like you would see hyperglycemic, hyperosmolar state, or sometimes it is referred to as diabetic hyperosmolar hyperglycemic syndrome. The name itself is the clue. Hyperosmolar meaning the osmolality or osmolarity is greater than 320. The normal is this 275 to 295. Okay. And then hyperosmolar, so osmolarity is greater than 320. Hyperglycemic, glucose is greater than 600. But in contrast to the ketoacidosis with pH being 7.3 in DKA, in HHS you have a pH of greater than 7.4, and the serum bicarb would be greater than 15. So to diagnose hyperosmolar hyperglycemic state, the diagnosis would be based on a blood glucose level of 600 or greater, osmolality of 320 or greater, profound dehydration, a serum pH greater than 7.4, a bicarb concentration greater than 15, and you will see very low ketonuria or no ketonuria at all. And you will also see alteration in the level of consciousness. So the treatment for DKA would be fluid replacement with isotonic normal saline, correction of electrolyte imbalances, focusing on monitoring and correction of hypokalemia, and also insulin administration, usually by intravenous delivery. The treatment for HHS, on the other hand, would also be IV fluid and also IV insulin to correct the hyperglycemia. Hyperosmolar hyperglycemic state usually presents in older patients with type 2 diabetes and carries a higher mortality rate than DKA, estimated at approximately 10 to 20%. Hyperosmolar hyperglycemic state most commonly occurs in patients who have some concomitant illness that leads to reduced fluid intake. Infection is the most common preceding illness. You just have to read this box on an ion gap, but the more important thing to remember is that the normal anion gap is between 8 to 16. However, this normal range is lab dependent, so therefore, you might see a normal anion gap between 3 to 11. For test purposes, we will stick with your textbook, which is 12 plus or minus 4. In other words, a range of 8 to 16. Another thing you need to know is that in DKA, the anion gap is elevated. And as the patient improves, the anion gap should normalize. So that's how they monitor that a person with a DKA is getting better. This is a continuation of a comparison between DKA and HHS. So with both DKA and HHS, the fluid status, they're both dehydrated. So the treatment would be isotonic IV fluid. Being dehydrated, you would expect the BUN and the creatinine to be elevated. By now, you should know the normal values of BUN and creatinine. And because of dehydration, more likely than not, uh, the person with DKA or HHS will be hypovolemic. So when the person is hypovolemic, that person is more likely than not will be hypotensive. And with hypotension, uh, there will be a compensatory mechanism of tachycardia. And of all the electrolytes that you need to monitor in either DKA or HHS would be the potassium. Okay, potassium. So in your book, the safety alert says monitoring and correcting potassium imbalances are essential in the treatment of DKA. Initially, hyperkalemia may be present because of the movement of positively charged potassium ions out of the cell in an effort to maintain homeostasis as positively charged hydrogen ions move into the cell as they accumulate in the extracellular fluid. Hypokalemia then ensues as a result of the loss of extracellular potassium in the urine because of the osmotic diuresis. This results in a severe total body loss of potassium, making the patient susceptible to lethal arrhythmias. Care must be taken to monitor potassium levels prior to treating the hyperglycemia with insulin. As insulin is administered to decrease hyperglycemia, potassium will also move back into the cell, worsening the hypokalemia. If hypokalemia is present, potassium replacement is a priority. Okay. So this I'm just trying to explain again what was in this slide, safety alert. So in this blue circle is a cell, right? The major cation in the cell is what? It's potassium, right? So in diabetic ketoacidosis, you have a higher concentration of hydrogen. So the body will try to get rid of the hydrogen, right? How will the body get rid of that hydrogen? By peeing, that's one. A second way of getting rid of the hydrogen in the blood vessels or in the extracellular environment will be for the hydrogen to get into the cell. Or you could say, hide inside the cell. So if you are able to move the hydrogen into the cell, there will be less hydrogen here and the acidosis will improve, right? But in order for the hydrogen to get into the cell, it must exchange places with the potassium. Why? Because the cell has to maintain its electric charge. So in exchange of hydrogen getting into the cell, the potassium must leave the cell. So therefore, initially, you will have hyperkalemia, which would be a potassium level greater than 5.1. And then, so now you already have hyperkalemia, right? Because the hydrogen moved into the cell. So now the kidneys will try to get rid of the excess potassium by peeing the potassium. So you will then have decreased potassium, contributing to hypokalemia. So that's one mechanism of uh, losing potassium during DKA. Potassium, you lose potassium through the urine, right? Another mechanism of losing potassium is when insulin, okay, when when in the presence of insulin, the entry of potassium into the cell is also enhanced. So remember insulin in one of our earlier lectures, insulin is the key to enable the glucose uh, enter the cell, right? Cross the membrane from extracellular to intracellular. So just remember, even though, like in my mind, I'm I'm imagining that on my left hand I have insulin and on my right hand I have potassium and insulin is pushing me into the cell. So while glucose is entering the cell, potassium is also entering the cell. And so therefore you will have less potassium here in the blood or extracellular in the extracellular area, and so you will have hypokalemia. And another mechanism, this I read somewhere, I can't remember really the reference, but what it said was insulin also blocks the exit of potassium out of the cell. So potassium sometimes it is normal for potassium to leak little by little out of the cell. But in the presence of insulin, insulin blocks the exit of potassium out of the cell. So that's another mechanism why there will be hypokalemia in DKA. So what? Who cares about hypokalemia? Well, uh, potassium imbalance with potassium, think heart. Okay. So if you have hyperkalemia or hypokalemia, the risk of lethal arrhythmias uh, is high. Okay. So the management of DKA and HHS, first and foremost, is fluid replacement with isotonic normal saline. And then potassium imbalance is addressed and monitored. Okay, so read again the safety alert. So I don't know why it did that, but that heart is supposed to be here. Potassium, think heart arrhythmias. And then, because there's hyperglycemia in both DKA and HHS, the treatment or management is IV insulin. Okay. But IV insulin only after adequate fluids have been replaced here, number one, and potassium should at least be 3.3 milliequivalents. That's not A, that should be Q. Milliequivalents per liter before insulin therapy is initiated. So you have to first correct the hypokalemia. Because if you don't correct the hypokalemia, introducing insulin will worsen the hypokalemia, and therefore you run the risk of lethal arrhythmias. So, sick day rules. Your book doesn't discuss the sick day rules, but sick day rules are important because uh, this being sick is what precipitates either DKA or HHS, or some of the time being sick is the precipitating factor for DKA or HHS. So what you need to teach your patient with diabetes is when they're sick, they need to monitor blood glucose at least every 4 hours. And when their blood glucose is greater than 240, they need to test urine for ketones. They also need to continue to take insulin or oral anti-diabetic agents. Okay? And they need to continue to eat meals at regular times. If they are unable to tolerate solid food because of nausea, they, they should consume more easily tolerated foods or liquids equal to the carbohydrate content of their usual meal. So the important thing is for them to continue to take insulin. Because if you remember, right, glucose can come from eating, but also glucose can come from gluconeogenesis, right? In other words, glucose can come from outside of the body, but glucose can also come from stores, right? So they're thinking, I'm not eating anyway, I might as well skip my insulin or my oral anti-hyperglycemic drug. No, when they're sick, they should still take insulin and also their oral anti-hyperglycemic drug. Um, I think that's the end. So I hope to see you in class, and please be prepared with your questions. And this is the last lecture for diabetes. Thank you.